Hey everyone, and welcome back to Study Nurse IQ. I'm Jenny. Today we're going to dive into the world of ACE inhibitors. These are powerhouse medications that you absolutely must master for nursing school and the NCLEX. And before you finish this video, don't forget to access the free quiz playlist. It's designed to test you specifically on this medication, so you can lock in this knowledge right away. Let's get started. To help us learn this medication, we're going to use the powerful mnemonic NURSE. This structure will guide us through the name, what the drug is used for, our nursing responsibilities, expected side effects, and crucial patient education pieces. N, name and mechanism of action. The very first step is understanding the name itself. The letters ACE stand for angiotensin converting enzyme. To truly understand an ACE inhibitor, you have to understand the RAS, the renin-angiotensin-aldosterone system. This system is the body's main tool for raising blood pressure when it senses pressure dropping too low, like in states of shock or dehydration. Here is the RAS pathway in a nutshell. Low blood pressure is sensed by the kidneys. The kidneys release renin. Renin converts a liver protein, angiotensinogen, into angiotensin 1. This is the critical step. Angiotensin-converting enzyme AC is what converts the inactive angiotensin 1 into the highly potent active hormone, angiotensin 2. Angiotensin 2 is the villain we need to stop because it causes two major problems for a failing heart. Massive vasoconstriction. It squeezes all the blood vessels, spiking the blood pressure. Aldosterone release. It triggers aldosterone, which tells the kidneys to keep sodium, Na+, and water, H2O, increasing overall blood volume. The inhibitor's action, the two-part punch. When we give an ACE inhibitor, we are blocking that key ACE enzyme. This causes two major therapeutic effects. Punch 1, lowering blood pressure. By inhibiting ACE, we prevent the creation of angiotensin 2. This leads to vasodilation. Blood vessels relax, which decreases systemic vascular resistance and lowers blood pressure, BP. Diuretic effect. We suppress aldosterone. This causes the kidneys to excrete, get rid of sodium and water, reducing overall blood volume. Punch 2, the bradykinin effect, the side effect maker. ACE isn't just responsible for making angiotensin 2, it also breaks down a substance called bradykinin. Bradykinin is a natural vasodilator that causes blood vessels to relax. When you block ACE, you block the enzyme that breaks down bradykinin. Result: bradykinin levels increase. This causes further beneficial vasodilation, but unfortunately, it's also responsible for the medication's most famous side effect, a persistent, annoying dry cough. Section 2. Now that we understand what ACE inhibitors are and how they work in the body, let's move to the next part of our nurse mnemonic. U for their uses. ACE inhibitors are incredibly versatile. Remember, their primary action is to reduce resistance and reduce fluid volume. Indication details. Hypertension, high blood pressure. The benefit is direct vasodilation and volume reduction, which lowers BP. Heart failure, HF, specifically systolic dysfunction. The benefit is that it decreases afterload, the resistance the heart has to pump against, and preload, the fluid volume returning to the heart, making it much easier for the failing left ventricle to pump blood forward. They are used to limit ventricular remodeling and damage to the heart muscle after a heart attack. Diabetic nephropathy. They are often renal protective, particularly in patients with diabetes, by reducing pressure inside the kidney's glomeruli. Section 3 are nurse responsibilities. Our role as the nurse centers around monitoring for the drug's therapeutic effects and anticipating its critical side effects. Monitoring and action points. Blood pressure and pulse. Nursing action. Monitor vital signs every 4 to 8 hours and before administration. Rationale. There is a risk of hypotension. Hold the drug if the systolic BP is less than 90 or if the patient is symptomatic, dizziness. Potassium levels. Nursing action, monitor serum K levels regularly. Rationale: ACE inhibitors can cause the kidneys to retain potassium, leading to hyperkalemia. Normal K is 3.5 to 5.0 milliamps per liter. Watch for tall, peak T waves on the EKG. Renal function. Nursing action, monitor BUN and creatinine. Rationale: the drug alters kidney function. Normal BUN is 5 and is 20 milligrams per deciliter, and normal creatinine is 0.6 to 0.2 milligrams per deciliter. Angioedema assessment. Nursing action, assess for swelling of the face, mouth, tongue, and extremities. Rationale. This is a rare but life-threatening allergic reaction. If swelling occurs, stop the drug immediately and prepare for emergency airway management. This is more common in African American patients. Cough distinction. Nursing action. Determine if a new cough is the benign dry cough or a sign of heart failure exacerbation. Rationale. Listen to lung sounds. Crackles, shortness of breath on exertion, and worsening edema indicate fluid overload HF, not just a drug side effect. Side effects. The three biggest side effects of ACE inhibitors are the ones you must remember for every exam. Dry, non-productive cough, caused by the buildup of bradykinin. It's harmless, but often so persistent that the patient must switch medications. Hyperkalemia, increased K, caused by the suppression of aldosterone, leading to potassium retention. Angioedema, rapid, life-threatening swelling of the deep tissues, which can close the airway. This requires immediate medical intervention. Education. Patient safety and adherence are key. Your education should focus on self-monitoring and avoiding dangerous drug interactions. Self-monitoring. Teach the patient to check their BP and pulse daily and keep a log to share with the healthcare provider. Change positions slowly. Because the drug causes vasodilation and can lead to orthostatic hypotension, instruct the patient to rise slowly from sitting or lying down to prevent dizziness and falls. Potassium restriction. Educate the patient to avoid salt substitutes, which contain potassium chloride, and to limit foods rich in potassium: bananas, potatoes, leafy greens, oranges, tomatoes. This is especially critical if they are also taking potassium-sparing diuretics like spironolactone. Never stop abruptly. Warn the patient that stopping the medication suddenly can cause dangerous rebound hypertension, where their BP spikes to an even higher level. They must consult their physician if they want to stop taking it due to side effects. Missed doses. If they miss a dose and remember the same day, they should take it. If they don't remember until the next day, they should skip the missed dose and take the scheduled dose. Never double dose. NCLEX style practice questions. Question 1. The nurse is teaching a patient starting lisinopril, an ACE inhibitor. Which statement by the patient indicates a need for immediate further education? A. I will call the doctor right away if my lips or face begin to swell. B. I will use a salt substitute instead of table salt to help control my blood pressure. C. I know I need to change positions slowly when getting out of bed. If I get a persistent dry cough, I will tell my doctor on my next visit. The correct answer is B. I will use a salt substitute instead of table salt to help control my blood pressure. Rationale. Salt substitutes typically contain potassium chloride. Since ACE inhibitors already cause potassium retention, risk of hyperkalemia, adding high amounts of potassium from salt substitutes significantly increases the risk of life-threatening hyperkalemia. Question 2. Which laboratory value requires the most immediate attention from the nurse when a patient is receiving an ACE inhibitor like captopril? A. Sodium 4140 molar. B. Blood urea nitrogen of 15 milligrams. C. Potassium K of 5.8. D. Creatinine of 1 aeromilliliter. The correct answer is C. Potassium K of 5.8 per liter. Rationale. The normal potassium range is 3.5 to 5.0 milliliters per liter. A value of 5.8 is elevated, hyperkalemia, and can lead to dangerous cardiac dysrhythmias, which must be addressed immediately. The other values are within or near normal limits. Question 3. A patient taking ramipril is complaining of a persistent, non-productive dry cough. The nurse understands this is a result of which mechanism of the medication? A. Inhibition of angiotensin II causing excessive vasodilation. B. The buildup of aldosterone causing fluid to back up in the lungs. C. The increase of bradykinin levels stimulating inflammatory receptors. The diuretic effect leading to chronic dry mucous membranes. The correct answer is C. The increase of bradykinin levels stimulating inflammatory receptors. Rationale. ACE, angiotensin converting enzyme, is normally responsible for breaking down bradykinin. When ACE is inhibited, bradykinin levels increase. While bradykinin causes beneficial vasodilation, It also triggers inflammatory receptors in the respiratory tract, leading to the characteristic dry cough. And there you have it, a complete breakdown of ACE inhibitors. You now know the name, the mechanism, the side effects, and exactly what to look for on your exams. Remember to like this video, subscribe for more pharmacology content, and most importantly, click that quiz link below to test your knowledge. I'll see you in the next video.